This is a huge topic, abdominal ultrasound. There's so many potential applications at the bedside for emergency physicians. However, this is a 45-minute talk, so we're going to confine ourselves to the kind of the highlights. And we're going to be talking about gallbladder pathology, some kidney stones and kidney pathology, and most importantly, abdominal aortic pathology, AAAs. I'd like to start with the abdominal aorta to emphasize its importance. It's the vascular emergencies that are truly emergent. These are things that can kill your patient in a matter of seconds or minutes. You'd be hard-pressed to have your patient who has gallstones or kidney stones to die within minutes or seconds after you lay hands on them. And if your patients are running into that outcome, probably you need to examine what you're doing to those patients. But the abdominal aorta is a ticking time bomb. Not the least of your worries is the need to send these patients to CT scan, often referred to as the tunnel of death. What you see missing from this picture, it's a beautiful CT scanner, and I've got nothing against radiologists, but what you see missing is any advanced airway equipment, any patient monitoring ability. There's probably some Benadryl and epinephrine on that cart for the occasional anaphylactic reaction, but that's about it. So if you've got an unstable or potentially unstable patient that you're worried about a AAA that's rupturing or nearly going to rupture, you best not send the patient out of your emergency department. And if your hospital is anything like where I work, the CT scanner is located about a quarter of a mile away from the emergency department. I'd rather not find out that my critically ill, quasi-stable patient had a bad outcome at the same time that everybody else in the hospital finds out about it when they announce the code blue overhead. I have a picture of Albert Einstein up here because he died of a AAA. Supposedly he knew that he had AAA and refused to have surgery because he was worried about the risks of surgery. This slide does illustrate that the mortality with emergent surgical repair is quite high. So if you wait until you're rupturing or having severe symptoms and you need to be rushed to the OR, you've got a 50% chance of making it out. Whereas if you can spot this earlier than the rupturing stage, 4% mortality. So hopefully after this lecture, you guys will be equipped to save the next generation of Albert Einsteins. Typically, the onset age is 50. Peak incidence occurs at age 80. It would probably, the peak incidence would continue to advance, but folks greater than 80 tend to die of other causes or of their AAA, so that kind of dies off a bit. These are the risk factors or associations of AAA. So family history of AAA, very important to ask about. Hypertension is almost universal. History of smoking, history of coronary artery disease, more prevalent in Caucasians. Let's talk about some anatomy. This is just a general review. There's not too much involved with the anatomy of the aorta. It's basically a hollow tube that conveys blood from point A to point B. This is just the intra-abdominal portion. It's a retroperitoneal organ. All the intraperitoneal stuff has been stripped off for the purposes of this slide. You can see, let me just move the pointer here. If I get in your way, just let me know. I'm going to try to crouch down. The celiac trunk comes off first, and then the SMA right below that. And you're going to be able to see that very easily on ultrasound. And then the main aorta courses down. The renal arteries come off just a little bit below the SMA here and there. And those are very difficult to see, so you're probably not going to run into those ultrasonographically. Here's the IMA, inferior mesenteric artery, also hard to spot. And then the aorta branches into the common iliacs here. What's illustrated in yellow here is the typical location of an aortic aneurysm. It tends to be below the level of the renal arteries. This is a fusiform aneurysm, which is the most common type of aneurysm. So it's basically a general dilatation of the aorta. Again, arising below the renals. It can extend into the common iliacs. So that's why it's crucial when you're doing your ultrasounds to image the entire aorta all the way down to the bifurcation of the aorta into the iliacs. And we'll demonstrate that. This is the other type of aneurysm that you may see. It's called a saccular aneurysm. It's just a little outpouching of one of the walls of the aorta. And these are rare. These are 10% of cases. I've not seen one, but the fact that these exist and are 1 in 10 means that you need to image the entire aorta from epigastrium all the way down to the bifurcation so that you know that you're not missing a small aneurysm. What are the indications for scanning? If you're looking for AAA, you've got a large variety of reasons why AAA may cause symptoms, and so it's not hard to find an indication to look. The classic triad of a AAA that's rupturing is abdominal pain, a pulsatile mass, and hypotension. Even though it's the classic description, it's certainly the minority of cases. In fact, probably you're going to see more cases that present as flank pain, and it may be misdiagnosed at some point previously as a kidney stone. The left side is going to be more affected than the right because the aorta is located on the left side of the body. And also when it ruptures and ruptures retroperitoneally, that'll affect the left side more often. It can also cause groin pain, particularly if a AAA is moving down to involve the common iliacs. Low back pain is a very common presentation. Syncope, if your patient is syncopized from their AAA, likely they've started the rupturing process. It's a good thing that the rupture occurs retroperitoneally as well, because if it happened intraperitoneally, your patients would die over a matter of seconds, guaranteed. You just bleed out your entire blood volume over the course of one cardiac cycle, versus the retroperitoneum has some possible chance of containing that hematoma for you to get them to the OR. The amount of clot that can form in a AAA, you're going to see some images that illustrate this, can cause problems distally. You can have embolization of the clot, and that can cause an acute arterial occlusion of the leg. It can cause something called blue toe syndrome. We see plenty of blue toe syndrome where I work, and one of the things to look for is a AAA. If the aorta gets too close and too large to other structures, it can fistulize, and so you can get an aortocaval fistula and develop high output failure from that. So this might be a thing to look for in a shock state where you've got high output failure. And if it fistulizes to the bowel, you're going to have a brisk GI bleed. So a lot of different indications. Feel free to lay the probe down on the patient's belly pretty liberally. And this is how you do it. So this video shows we're scanning in the transverse. We're cutting left to right. The probe marker, according to the golden rule, is pointed towards the patient's right side. And you can either start in the epigastrium or start, as I like to do, right above the umbilicus. The umbilicus is located at about L4, which is the level of the bifurcation of the aorta. So starting there, you're going to pick up the vast majority of your AAAs. Remember that most are low down. And you want to gradually progress up to the epigastrium to visualize the entire aorta. While you're imaging right above the umbilicus, it's also important to direct the probe inferiorly. Direct it down a little bit into the lower abdomen until you can see the bifurcation. This is another clip that just shows the transition from a transverse look where the probe marker is facing the patient's right to a longitudinal or sagittal cut where the probe marker is now facing the patient's head. And so this is very easy to do. What you'll want to do is you'll find the aorta on transverse. It'll look like a big circle. And then you put that circle directly in the center of your screen and rotate 90 degrees so that the probe marker is now facing the patient's head. And you're going to see that circular structure turn into a tubular structure. You can be able to visualize it over its entire course. We'll show some video. Here's a still image which shows our abdominal aorta and some other associated anatomy. The first thing that you want to look for is what's indicated with this arrow. It's this bright white hemicircle here with a dark shadow beyond it. That's the vertebral body, and here's the shadowing beyond it. That'll orient you to finding your abdominal aorta. This is a transverse scan now in the epigastrium, and right above the spine on the left side of the patient. Notice that the blue marker here, which corresponds to the blue dot or the dot on your probe, is over on this side of the screen. It's on the left side of the screen, which corresponds to the right side of the patient. So therefore, this is the left side of the patient. That's the aorta. And that makes this the IVC. Okay, notice the IVC has a little bit of a collapsed looking shape here. It's not quite as round. The pressures are considerably less in the IVC, and so it can collapse. And it will have that respiratory variation that Sarah mentioned. Right on top of the aorta in the epigastrium is a smaller circle that's surrounded by bright white. And that bright white is fat and connective tissue surrounding the SMA, and that's what this is. And that'll help orient you as well if you can see this bright white structure right on top of a slightly larger circle. Up here we have the left lobe of the liver. Okay, here's a video. Again, the first thing you want to look for is looking for the vertebral body right there, and then the shadow that's associated with that. So you know that you're right on top of the spine, so just go a little bit above that, a little bit closer to the transducer, and you've got your aorta. And while we're here, let's round out the rest of the anatomy. This is the IVC right here, right next to the aorta on the patient's right. Here's the SMA right above the aorta. This happens to be the splenic vein. Right above that is the pancreas. And this is a bonus clip. We happen to have a gallbladder right here with some stones in it, casting shadows. It wouldn't be a county patient if it didn't come fully equipped with gallstones. All right. Again, this is another clip of the epigastric aorta. You see the pancreas in the foreground. Again, below that, the splenic vein. See the SMA right here. Aorta. And vertebral body with shadow. The IVC is almost invisible here because it's so collapsed. It's right here. So this is how the aorta looks in the epigastrium. This is scanning a little bit lower down. Okay, so now we just have a vertebral body to orient us, which is shown here. You just see the anterior part of it. It's solid bone, so it's going to cast a broad shadow beyond it, which is here. Look directly above it, and you've got this gigantic structure here fixing to explode, and that would be a AAA. You can estimate the size, even though it's not measured on this video clip, by these hash marks here. So each one of these is a centimeter, so this is 3 to 4 centimeters. Let's talk about measurements. You want to measure the aorta from outer wall to outer wall. This is because a lot of times in a AAA there's going to be quite a bit of clot that's built up in the aorta. And if you just measure what you think is the lumen of the aorta, you're going to significantly underestimate the aorta. And we'll see an image of this. You also want to measure, ideally, in a transverse cut, so cutting left to right in the AP diameter. So you put your measurement, basically anterior to posterior. We'll show an image of how to do this. 2 centimeters or less is normal. Greater than 3 centimeters is a AAA. In a symptomatic patient, you want to assume that the symptoms are being caused by the AAA until you can prove otherwise. All right, bowel gas, I said it's your enemy. You need to know how to avoid this. Otherwise, a lot of your scans are going to be inadequate. So gentle, steady downward pressure. Just try to manipulate that gas out of your way. Don't give up. Spend some time with it. You can try to angle around the gas by going slightly to the left or to the right. And you can also try scanning coronally from the side to avoid the gas entirely. If you happen to pick up a AAA, again, assume that it's the cause of the symptoms that prompted you to look in the first place, and assume that it's serious. Get your consultants involved. If after the evaluation it's determined that it's not the cause, then they'll need to be referred. And generally, if the AAA is between 3 and 4.5 centimeters, they'll need serial Q6 months checks. If it's greater than 4.5, then refer directly to vascular surgery, and they can fix it. So several pitfalls. Bowel gas, we talked about that. Not visualizing completely. Mixing up the IVC and the aorta. Measuring in the incorrect plane. Remember, it's got to be AP transverse. And measuring inner wall to inner wall. Biggest failing is probably to consider it on your differential and just assume that that flank pain was actually a kidney stone. So some symptoms that might prompt you to look for gallstones. Right upper quadrant pain is the obvious choice. Also consider just putting the probe on if you've got a case of jaundice and there's no clear etiology. And of course, if you've got a febrile patient and you can't find another source, maybe they're altered and you're not sure if they do have abdominal pain, maybe they're elderly or they might have a relatively benign exam, they might still have a very nasty looking gallbladder. The diseases that we're going to be able to pick up on a bedside ultrasound are cholelithiasis, cholecystitis. As you get good and as you start to be able to visualize the common bile duct, you can pick up things like choledocholithiasis, ascending cholangitis, given the right clinical picture, and then gallstone pancreatitis. We're going to focus today on looking at gallstones and some of the signs of cholecystitis in the interest of time. So gallstones are something that that's the main thing we're going to go over today. You can get an estimate of the gallbladder size. You should assess as well for sonographic Murphy's sign, just the equivalent of the Murphy's sign, but pressing with the ultrasound probe right over the fundus. It's very easy to look for gallbladder wall thickening. We'll show some examples. Some other things that you might pick up are pericholecystic fluid, a rim of fluid around the gallbladder, and the common bile duct size. We won't discuss that so much today. Where to place the probe? There's lots of different possibilities given the variability of the location of the gallbladder. My personal recommendation is that you start looking intercostally in the midclavicular line as your first choice. So just draw a line from the nipple down and just go between the last few ribs. And a lot of the time, the gallbladder is just going to pop into your view. If that doesn't work, you can try a subcostal approach, so just slightly lower. This patient came equipped with little probe markers, circles on him. Helped tremendously. And then if that doesn't work, you can also lay the patient on their side and look subcostally. This patient's at a little bit of a oblique left lateral decube. You can even put the patient completely on their side and allow the gallbladder to sort of roll into your view as it swings underneath the liver. Here's a still image which illustrates gallbladder anatomy and the related structures. So the liver is this homogeneous looking structure. Gallbladder is a sac filled straight in the center. This bright white line off to the side is the diaphragm. And then the main vessel that you see coursing through here is the portal vein. There's a clip showing a view of Morrison's that sort of gets the gallbladder. Illustrates again, the liver is right here. The diaphragm, this bright white line is up here. Right in the center is the portal vein. And I refer to this as the North Star of the liver. It kind of guides you to the gallbladder because the gallbladder tends to point to the portal vein like an exclamation mark on its side. So this is the dot of the exclamation mark, and this is the line of it. This, of course, the kidney right here. Got another normal gallbladder. What you want to do when you're looking at the gallbladder is scan through the entire gallbladder, looking for any bright white structure within the lumen of the gallbladder that casts a shadow beyond it. So it's not enough to just see a static image of the gallbladder as well. You need to take your hand and just rock your hand through the entire segment of the gallbladder. Here's a gallbladder that's just riddled with stones. All these white structures, stones that have gathered, they're layering on the bottom of the gallbladder, and they're casting this dense shadow beyond them. It's almost like a curtain of shadow that occurs underneath this. Kind of obliterates the structures underlying the gallbladder. You can't really appreciate them. So gallstones should be echogenic. That means that they're white, and they should cast a shadow. Don't call something a stone if you don't see an associated shadow, because there are some other things that might appear to be stones, might appear to be white, and yet they don't cast that nice dark shadow beyond them. They have to be within the gallbladder. There's a lot of things right around the gallbladder, right outside of the gallbladder wall or adjacent, that will cast shadows, and you shouldn't be calling those stones either. And they're going to, for the most part, be mobile. That is, if you move the patient onto their side, you might expect the gallstone to tumble around a little bit and to assume the most dependent portion. They're going to gather at the bottom of the gallbladder, whichever way bottom is, according to where you're scanning. Here's a still image just showing a gallstone lodged near the neck of the gallbladder. So the fundus of the gallbladder is up here. This is headed towards the cystic duct, and this gallstone is casting a dense shadow here. So it's clearly a white structure within the lumen of the gallbladder. It's casting a black shadow. That you can call a gallstone. Again, you have these white structures here with a dark shadow underneath them. This is a gallbladder full of gallstones. Okay, a different view. This one incorporates more of the liver. But up in this corner, here's the gallbladder. And even though it's hard to distinguish the individual stones here in this gallbladder, you can see as we fan in and out that there are some white dots inside the lumen there, and they're casting this curtain of shadow beyond it. This is a much more subtle picture of some gallstones, because these are tiny little gallstones. They're located way up in the fundus of this gallbladder. This is the top, this is the fundus of the gallbladder. See these tiny little calcifications, and each one has a little micro shadow beyond it. It's difficult to see any gallstones down at the base of the gallbladder, but way up in the fundus you can see these tiny little streaks there. So that also illustrates how important it is to visualize the entire gallbladder if you're concerned with stones. That's the reason for the symptoms. This is hard to miss, right? And yet it's only in one place of the gallbladder. It's only up in the fundus. The stone is kind of sitting here, hanging out, casting a dense shadow. Yeah. And then here's the neck of the gallbladder and not a stone in sight. So crucial to look through the entire gallbladder. All right, this is a different clip here. Kind of an interesting looking gallbladder here. So liver off to the side, gallbladder front and center. And then there's this thick white substance here. And you might be tempted to call that stone. But notice that there's no shadow beyond it. The gain is a little bit high in this image. The volume is a little bit turned up too high. But still, there's not a shadow in sight beyond it. And so this is referred to as sludge. Okay? It's probably very similar to the composition of gallstones, but it doesn't cast that shadow. Something that you might see with a bad case of cholecystitis. You might see it in your hospitalized intensive care unit patients who have been critically ill for a matter of days to weeks. They might develop this sludge in their gallbladder. This case was acute cholecystitis. How about this gallbladder? Are there any stones here? We're scanning with the patient supine. Who thinks there's a stone? A few hands. Most people say no. Well, there's something up here, right? Something up here, and it's casting this shadow. So it's clearly within the lumen of the gallbladder, and it's casting a shadow. There's another shadow over here that you may have noticed, and this is what's referred to as edge artifact, this shadow right here. So as the gallbladder wall comes into the ultrasound beam, and basically as the wall looks thick to the ultrasound beam, because so much of it is running parallel to the ultrasound beam, it's going to cause this shadowing artifact right on the edge. Since there's no stone associated with this edge artifact, you can safely call this edge artifact. But this shadow seems definitely to be coming from these structures here. But the one thing that's unusual about this is that I said gallstones are mobile, and they should go to the most dependent portion of the gallbladder. These ones look like they're stuck on the wall. So that can happen. It can be a gallstone that's, for some reason, through previous inflammation, has become adherent to the wall of the gallbladder. But it could also be a polyp that's calcified and is now shadowing, or it could be a cancer. And I don't want any of us to just call this a gallstone and be done with it. If you see something that looks like this patient is going to need a referral for a formal study to make sure that this is not something much worse than gallstones. All right, now, again, we're scanning right upper quadrant. You've got the liver here. Here you've got the north pole, the portal vein, intermittently here. Here it is, kind of guiding you to where you expect to see the gallbladder. So if it's that exclamation sign, you should expect the gallbladder right here. Instead, what you see is one dense shadow. What's going on with this patient? Has this patient had their gallbladder removed, and did the surgeon have dirty hands and leave something behind that might shadow? I guess that's possible. What you see here instead is this gallbladder is so densely packed with stones that the entire gallbladder is just shadowing. It's just one big shadow. So it's this curtain of shadow. The other possibility is that it could be a porcelain gallbladder. The gallbladder wall is calcified, so you can't see the center of the gallbladder. This is referred to as the wall echo shadow sign, or the West sign. Basically, as the ultrasound beam strikes the front wall of the gallbladder, you get the wall, and then it runs into this thick wall of stones. And that causes an echo, or a bright signal. And then everything beyond this is just shadow. You can't even see beyond a couple millimeters here. You're just going to get the first layer of stones. All these other stones go undetected, and you just infer that they're there because this is all shadowed out. So this gallbladder is chock full of stones. How about these? Scanning again, right upper quadrant. You've got a gallbladder right in the center. There's no shadow, and that's the key finding here. So you've got something adherent to the front wall. You've got something down here on the back wall. No shadow. These are not stones. And these turned out to be polyps. Again, don't call something a polyp without arranging a formal study as well, because some subtle cancers can appear like this as well. There's another pitfall. Okay, right upper quadrant, liver, diaphragm down here, portal vein right here, gallbladder, and then there's this bright structure right on the, well, it appears to be in the lumen at times. At other times it appears to be right on the border. But you can see at some times it does not cast a shadow. When you think that you should clearly see a shadow beyond it, it's got no shadow associated with it. And at other times, when you're getting maybe more into the center of it, it casts what's called a dirty shadow. That's the dirty shadow that you see with bowel gas. It's kind of a streakiness. It's not the curtain of just a dark beam that you see with stones. So a very common pitfall with the gallbladder, because the colon is can lie right next to the gallbladder and indent the wall of the gallbladder a little bit and give you that artifact. So be very careful with that pitfall. Gallbladder is probably the hardest indication that I'm going to discuss today. The aorta, pretty straightforward. Not a whole lot that you can have a tough time finding with other than bowel gas. But the gallbladder often causes people problems, and I get called over a lot when I'm working in another part of the hospital to work in the emergency department and help find somebody's gallbladder. The first thing I would say, this is sort of my difficult gallbladder algorithm. First thing I would say is look intercostally in the midclavicular line. This is the place I recommend to start for everyone, and a lot of times it'll pop into view. If that doesn't work, go subcostally and see if the gallbladder might be in a different location. That doesn't work, roll the patient to some degree onto their left side. I would start with about 45 degrees. If that doesn't work, put them to 90 and look subcostally. And sometimes you're going to get the gallbladder to float into your view. Sorry, I skipped a point. Before you move them, put them in, go for Morrison's pouch, which is a lot easier to find, I think, than the gallbladder a lot of times. Once you've gotten Morrison's, you want to sort of scroll up along the liver and kidney edge. Just keep on migrating closer and closer to the midline until the gallbladder appears in your view. If that doesn't work, it's time to move the patient, put them in the left lateral DQ. At this point, I start looking for cholecystectomy scars or considering situs inversus, and then I'll give up and I'll just request the formal. Let's talk about some acute cholecystitis signs. A distended gallbladder is one. Gallbladder wall thickening, greater than 3 millimeters is the measurement you want to keep in mind. Pericholecystic fluid, a sonographic Murphy sign, and gallstones. Just know that gallstones plus gallbladder wall thickening has a 95% positive predictive value for acute cholecystitis. Gallstones and a sonographic Murphy's, 92% positive predictive value. A lot of different things can cause gallbladder wall thickening, so everything that causes this is not acute cholecystitis. For instance, if a patient just ate and their gallbladder is shrunken down, you're going to get a thick gallbladder wall. If they got low albumin, you're going to get a thick wall. A lot of these other things here that I've got listed will cause it. This is an illustration showing a gallstone, and the gallbladder wall is being measured here. You can see the cursor move, and this turns out to be greater than 3 millimeters. This is a typical appearance of a thick gallbladder wall. Always measure the gallbladder wall on the anterior surface, right as it's next to the liver. You could see how difficult it would be if you were trying to measure the posterior wall. You have no idea where this wall ends because of the acoustic enhancement. All this bright white, that normally appears behind a gallbladder. No idea where to put that cursor. So always measure this wall and try to get the gallbladder to lie on its side as much as possible, or diagonal. Another gallbladder wall that's thick. This one was from low albumin. This patient had nephrotic syndrome. You can see that there's a layer of edema in that gallbladder wall. So to summarize the gallbladder, you want to start intercostally at the midclavicular line. Make sure to scan through the entire gallbladder. 3 millimeters or more is abnormal with respect to the wall. And then the pitfalls that you should know about: bowel gas, patient's body habitus, polyps, or cancers. And then a stone at the neck of the gallbladder is a frequent place for stones to try to hide. Let's move on to renal. CT scan has largely replaced kidney ultrasound for the evaluation of urolithiasis. But with all the evidence that's coming out that CT scans are damaging people from excessive radiation, we might see a move towards using more bedside ultrasound. I think it certainly has a role in our patients who are recurrent stone formers who come in with their typical renal colic, a quick check of the kidneys and a quick check of the aorta to make sure it's not something more dangerous. And you can probably send that patient on their way without a CT scan. There's some other secondary indications that you can get into a little bit later, which we'll leave for a more advanced course. The main thing that we're going to be looking for is hydronephrosis, which is a backup of urine into the kidney, and we'll show you a lot of examples of this. Just to go over some basic anatomy, you have the liver with its capsule, cortex, and medulla, and then the center collecting system. And the one thing I want to point out here is all this fat that's tucked in around the renal sinus and around the collecting system. That's what gives the bright white appearance to the center of the kidney, and we'll see the ultrasound images of this. As urine backs up into the kidney and this collecting system distends, remember, water or urine is going to be black on ultrasound. Fluid is black. And so you're going to see a black puddle start to collect in the center of the kidney, in the center of that white portion of the kidney. Hydronephrosis can be very minimal to very severe. And as it gets more and more severe, you start to see some cortical thinning. You can see that this cortex right here has been considerably thinned out. We're going to place the probe in the intercostal space. We're going to try to sneak it between the ribs, or we might go below the ribs. Let's see some video of this. So on the right side, it's relatively straightforward. You have the liver to help you take advantage of that nice acoustic window. It's relatively easy to find the right kidney. On the left side, you really have to get your hand down pretty low. The spleen is much less forgiving, and the kidney can be tucked up pretty hard to find. And this image just illustrates just how far you might have to push your hands down. You're actually indenting the bed, the gurney, with your knuckles here. You're pushing deep down in there. Basic ultrasound anatomy of the kidney. So again, the center portion, the gain is a little bit high here as well, but the center portion is this white renal sinus, which is mostly fat, and since it's normal, there's no black collections of fluid in there. The outer rim of it appears black. This is the inferior pole. This is the upper pole of the kidney. Liver and diaphragm right next to it. Normal kidney. Going through the entire kidney. You see the center portion of the kidney appears white. The outer portion appears dark. Get a little peek at Morrison's pouch here. That's normal kidney, no hydronephrosis. Abnormal kidney. So this is on the left side because there's no liver. And you've got to look at the outer portion of the kidney is a normal appearance. It's gray, it's dark. And then you get a white central portion, which is being pushed out by the fluid that's backed up into the kidney. So this is mild hydronephrosis, mild to moderate hydronephrosis. Notice also that the fluid kind of forms this tree-like structure, broccoli-like structure. That tends to do that. Here's another look at hydronephrosis. A lot of cystic-looking structures in the center of the kidney that are all interconnected. So as you're scrolling through the kidney, as you're fanning through the kidney, you're going to see that all of these collections of water will collect down at the ureter. Okay, again, example of some small amount of fluid that's built up on the kidney. Again, a small amount of hydronephrosis. Just down here. So this will be mild hydronephrosis. This is the normal white sinus, and this is the cortex and medulla. What you do see on this clip are the renal pyramids, which are these dark structures out in the perimeter. So notice that hydronephrosis is going to collect centrally. These dark structures on the outside are normal renal architecture. So you're going to be focused on this white portion of the kidney and the black that collects in the center of that. I use just kind of a gestalt images. So this is severe hydro. You can see that the renal architecture is pretty damaged. You've seen some cases of mild. Moderate is in the middle of that, and I don't have a more scientific explanation than that. I don't do much beyond distinguish between severe and somewhat less than that. So,
between normal and mild hydro.
Well, normal is going to have that nice white center, and it's really not going to distend with a black puddle of fluid. So you're going to, in the lab, I think you'll get to see quite a bit of normal kidneys, and you'll get a good sense of the architecture there. This shows how these little small collections of hydronephrosis all gather at quite a significant hydroureter. So the ureter is more distended here in this case than the actual kidney is. See, the kidney here just has these three little pockets of hydro, and as you scroll through, there's this great big collection right at the kidney pelvis. Again, another look at hydro. Severe hydro where the cortex of this kidney is so thinned out, this patient probably doesn't have much function to this kidney. Let me skip ahead here. This one is to illustrate a kidney stone. So this is kind of a lucky finding if you get it. You have a bright white structure in the cortex of the kidney with a shadow beyond it. There's a kidney stone. You're not going to be looking for this in particular. You're mostly going to be looking for hydronephrosis, which is sort of an indirect sign of a kidney stone. This is the normal renal sinus here. Notice there's no shadow. So that's normal, as opposed to that stone that's casting that dark shadow. So here's a video showing the same thing. There's a stone right at the periphery of the renal pelvis here, or the renal sinus rather, with the dark shadow. There's this stone or calcification with a dark shadow. This is an interesting clip because it shows not only hydronephrosis, but that bone is finding there's a stone right here, very hard to see, with a shadow beyond it. This was a stone that was trapped at the ureteropelvic junction, one of the 3 common places for kidney stones to get trapped. So that was the reason for this patient's hydronephrosis. When you see a kidney that looks like this, the entire renal sinus looks like it's just casting a dense shadow. This is a staghorn calculus. So the entire renal pelvis is just full of stone here. Can't see anything beyond this kidney because the stones are just shadowing through. Okay, a couple pitfalls. Don't call this hydro. This is nowhere near the center of the kidney. This is down on the inferior pole, and it's this great big cystic structure. So this is a renal cyst, very common finding, but not to be confused with hydro. You know this because it's nowhere near the center. It's this very round circular structure with no internal echoes. There's no debris inside it. And beyond it, you get this bright white appearance. Remember that the sound speeds up going through the fluid, and then it hits the back wall, and it scatters, and it causes this bright white appearance beyond the kidney stone, beyond the cyst. This is another pitfall. This is actually, I would call this hydro 9 times out of 10 or 10 times out of 10, but it actually turns out it was a parapelvic cyst. Okay, so this can be quite complicated. I would say if you see this, you're going to call it hydronephrosis and go on with another study or go to the next imaging modality. How about this kidney? It looks unrecognizable. The entire architecture of this kidney has just been replaced with cysts. Here's the liver here for orientation, the diaphragm, and then we go below the next rib here, and here's the kidney, or where you expect the kidney to be, and it's just cysts. And this is polycystic kidney disease. Okay, and finishing up here, if you see something that doesn't look like a normal kidney, you need to move this patient on to the next study, either a referral or do something in the emergency department. Here's the kidney here. Here's the renal sinus, this white portion here, which looks like it's smushed. It's all compressed because you got this great big tumor that's sitting on the kidney. And so renal cell carcinoma, you'll pick it up if you're looking for flank pain or you're evaluating hematuria. See something that looks like this, don't blow it off. You've got to pursue it. This could be something very serious. So I just want to summarize the renal by talking about some of the pitfalls. If you see hydronephrosis on one side, please look on the other side. Because if you have bilateral hydronephrosis, especially in a woman, your differential diagnosis includes pelvic tumors, and you don't want to let that, don't want to just chalk the pain up to a kidney stone. So please look at both kidneys. We talked about cysts in the kidney. Remember, they're most often going to be out in the periphery and easy to distinguish. Pregnancy. In the pregnant state, you can often get a little bit of hydronephrosis as the fetus is pushing up on the ureters and preventing some outflow. So that doesn't necessarily mean a stone. It's not abnormal. Remember not to overlook AAA, sort of one of those standard board questions, right? The patient comes in with flank pain and some hematuria, and you chalk it up to a stone. It was actually a rupturing AAA. If the patient's very dehydrated, they might have a stone, and you might not be able to appreciate hydronephrosis. So you can hydrate them and repeat your study 30 minutes later, and you might be able to pick up some hydronephrosis at that point. Remember, if you see something that looks abnormal, it might be cancer, assume it is, refer, get them the appropriate follow-up. Remember, the renal pyramids are going to be out in the periphery and can mimic cysts. And ignore the stuff about the Collins and Burton. So that's all I got. I think we're going to be taking a break now.